So compliance, the measure of how pressure in a vessel wall will change. So just to remind ourselves here, low compliance in arteries, which means a small change in volume automatically creates a large change in pressure. And then veins on the other end are the opposite. High compliance, a large change in volume is required in order to make a large change in pressure. Let's shift gears and look at arterioles. Arterioles are slightly smaller than our arteries. They have the most resistance than any other branch of the vasculature, and they're considered a part of the microcirculation. So arterioles are going to be connecting arteries, right, like radial artery, brachial artery, those medium-sized arteries to capillaries, or in some cases, meta-arterioles. They're going to contain smooth muscle and therefore have a lot of resistance. And again, I keep reiterating this, that smooth muscle, the role of it is to be innervated by the nervous system, and then we can change that smooth muscle state and therefore change the radius of these vessels. So if we compare our arteries in terms of the pressure to our arterioles, we're going to notice that arterioles have the greatest resistance to blood flow, which is very important. They're also going to have the greater than 60% of the total peripheral resistance. Remember, all of the resistance across the vasculature on a whole, more than 60% of that is in the arterioles alone. And then they're also going to see the greatest drop off in pressure. So notice how pressure is pretty constant as we move through arteries, even our medium-sized arteries. When we get to arterioles, it's the greatest drop-off. We go from about 90 millimeters of mercury all the way down to about 40 millimeters of mercury because such resistance is encountered with the lumen and the smooth muscle of the arterioles. Now, the regulation here is basically what's changing the resistance. So as I increase the state or the contractility of my smooth muscle, I'm making the lumen smaller, therefore I'm adding more resistance. And if I were to vasodilate that smooth muscle, I'd make the lumen larger and I would decrease resistance. So we've talked about the relationship between resistance and radius size. And so that can be seen here, especially in arterioles as well. Looking at some of the other areas of the vasculature, capillaries, still a drop-off in pressure, not as great. And then venules and veins are low pressure to begin with. They're still slight dropping off, but not as steep as arterioles. So looking at that change in arterial radius, so this depends on the state of contractility of the smooth muscle, right? The tone of that smooth muscle. So we have contraction at the level of the smooth muscle, which tells us the radius of the lumen. And this is basically independent of extrinsic regulation, okay? So we can have vasoconstriction and vasodilation purely based on how much flow is coming through. And that would be what we call autorhythmic, or sort of the blood vessel regulating its own flow, while we do have other extrinsic factors like the nervous system, hormones, our overall state, that can be extrinsic and regulate the size as well. So the arteriolar tone is kind of within the blood vessel and based upon how much flow is coming through, right? We can have extrinsic and intrinsic factors. Now, with vasoconstriction, this is increased contraction. That's going to decrease the radius. So that's what's happening here. Same vessel, smooth muscle is now going to be tense or contracted. And so the lumen is smaller, which means we have a smaller radius and a larger resistance, right? Greater resistance. Alternatively, when we have vasodilation, we relax the state of the smooth muscle in that vessel wall, which is going to decrease its contraction, increase the radius of the lumen, and that will result in a larger lumen, less resistance, and then more flow, okay? So we can change or modify the state of the smooth muscle to change the resistance and the flow. Okay, now what we're going to move on to speak about here are some intrinsic mechanisms to control blood flow and how that blood flow is distributed to various organs. So we can regulate blood flow to organ systems based upon their need, right? I gave this example earlier that if you just had a large meal, your gastrointestinal system is working actively to digest and absorb. You're going to have blood shunting away from your skeletal muscles and other organs that are not being used or not acutely needed towards your GI tract. Alternatively, if you have not eaten for a while, or if you're running a marathon, or if you're, involved in some exertion or physical activity, if you're working out, you're going to shunt blood in the opposite direction, away from your GI organs and towards your skeletal muscle mass. So that regulation is really based on acute need, and it's a survival mechanism, if you look at it closely. Now, we can have that regulation based upon changing the resistance. And so organ blood flow is going to be equal to the mean arterial pressure divided by any organ resistance, right? That's going to determine how much flow is going to that vascular bed. The overall mean arterial pressure, the driving force, divided by the specific resistance to that organ system. Okay, so let's look at this schematic here and an example of that. So here we have our arteries, right? Our arterial pressure going towards these three organ systems, organ system A, B, and C, right? So blood is leaving the heart, moving through this branch of the vasculature, and then making its way evenly to these three vascular beds. And then similarly, blood is leaving these via the venules and veins. We have equal venule or vein pressure, and then going back towards the heart. Okay. And then the example here would be, let's say organ B system is my, I don't know, my peripheral skin, for example, or my gastrointestinal organs. Now, if I've just had a large meal, I'm going to modify the diameter of these vessels, right? I'm going to allow for vasodilation here to bring more blood to the GI tract. And I'm going to allow for vasoconstriction here to shunt it away from this system, and more of that can flow towards organ B. Okay, so just an example of how that regulation happens. Okay, another example here, kind of very similar example. So in scenario B, we have, or scenario A, excuse me, we have more flow. Flow is about 1.5 liters per minute, so about 50% of our total cardiac output. In scenario B, moderate flow, kind of in between, 1.0 liters per minute, about 33% of our total cardiac output. And then scenario C is even less, 0.5 in terms of that flow rate, and then about 17% total volume of the cardiac output. Okay. So this is an example. A might be one organ system like your brain. Your kidneys are very dependent on oxygen flow, on glucose, on good perfusion. So they're going to take a big chunk out of your cardiac output. The brain takes about 15 to 20%, and the kidneys take also about 20%. So you can consider those organ systems as more important. Therefore, the capillary beds, the arterioles to those organ systems are going to have a larger diameter, a higher flow rate, less resistance to be able to receive more of that cardiac output. Alternatively, other systems like your skin, for example, unless you're flushed and really hot, that's not going to get very much of your perfusion. So that might get scenario C, very little in terms of flow rate, more vasoconstriction happening, and then a smaller amount of your total cardiac output. Okay. All right. And then looking at what that looks like with vasoconstriction. So notice that when I vasoconstrict to the organ system B, I result in more flow to organ system A and more flow to organ system C, right? Now we're at 60% with the brain, and we end up having about 20% for organ system C. So vasoconstriction in one area results automatically in that blood having to find somewhere else to go, and so more flow or vasodilation to other systems. So we're continuing to look at intrinsic factors here, right? Intrinsic control of blood flow and blood distribution. Now, they're going to be local factors that control vascular resistance. And this depends on the state of the smooth muscle in the vessel wall, and then other local factors, and this can be the amount of carbon dioxide at the tissue bed, the amount of oxygen at the tissue bed, the amount of flow coming through in that vessel wall. So these are intrinsic factors, local factors that regulate the size of the radius, therefore regulating the overall flow, right? Decreasing resistance and flow. So one example of that is changes in response to metabolic activity, okay? So we can usually see increased metabolic activity causing vasodilation, right? If you have more of these metabolic byproducts like carbon dioxide, like potassium ions, like hydrogen ions, if you have more of those metabolic byproducts in your tissues, automatically, based upon a local response, you're going to have relaxation of the smooth muscle in your vessel, and then vasodilation, allowing for increase in the vessel radius. Okay. And then alternatively, if you have more oxygen, right, the tissue is going to be well perfused, well oxygenated. That is a signal that we can slow down on the flow. Okay. That's going to decrease the or rather increase the state and contraction of the smooth muscle, and that will bring about vasoconstriction, which will decrease the lumen size and increase the resistance. So these are local tissue factors that can modify the vessel radius by modifying smooth muscle and therefore the flow. Other factors, such example, active hyperemia. So if you have increased blood flow in response to increased metabolic activity, again, that smooth muscle, that muscle exercise example is a classic example. If your muscles are under increased metabolic activity and they demand more oxygen, then we're going to have vasodilation to bring that flow. So during steady state, adequate amounts of oxygen is being delivered, adequate amounts of CO2 is being removed, okay? So we are delivering oxygen as fast as it is being consumed, and we are removing CO2 as fast as it is being produced. So this is what's happening under ideal circumstances. You're at rest, you're at steady state, and there's not really an increased metabolic demand or need, okay? Let's see here. Okay, yes, someone's asking me to go back one slide briefly. Okay, perfect. All righty. So that was steady state, things are normal. And then let's think about increased metabolic activity, increased metabolic rate. Now you are consuming oxygen faster than it can be delivered to that tissue. Right now you're going to go into an oxygen deficit. You're also producing CO2 faster than it can be cleared. Right now you're going to have a backlog of CO2. So you'll have less CO2 than you need, or excuse me, less oxygen than you need, and you'll have more CO2 building up in that tissue. Both of those are triggers to have increase in the lumen, right? Both of those are triggers to have relaxation of the smooth muscle, increase in the radius, and more flow to that tissue. So the response to low oxygen, high CO2 is vasodilation, which is what increases blood flow. Okay, that's going to bring in more oxygen while simultaneously clearing away more of that CO2. Okay, so here's the example, right? Here's carbon dioxide in green, oxygen in purple. And so here's blood flow coming into the tissue. Notice in this instance, we have steady states or normal absorption of oxygen matching release of CO2, right? So that relationship is at steady state. Now, if we have increased metabolic activity, what we're going to see is more CO2 building up, right? Notice we have much more CO2 floating around here and much less oxygen. So that is telling us now that we need more flow. So the response is we're going to increase the vessel diameter, which we're seeing here, allowing for vasodilation, and that can allow us to match that rate of oxygenation and match that rate of clearing CO2 to what the tissue is demanding and releasing at that time. So now we're going to return to a place of steady state once we increase the vessel diameter. Okay. Right. Now, another thing to think about is increased blood flow in response to a previous reduction in blood flow. So the first instance was to match the metabolic activity. The second instance is sort of a responsive mechanism, so to correct a previous shutoff in blood flow. And this may have been an instance of, let's say you had a blockage to tissue and you have the metabolites such as CO2, potassium building up in that tissue and oxygen decreasing. You're going to want to correct that. Although the tissue is not demanding more, because there was a previous blockage, maybe an injury, maybe a state of compression of a vessel or a state of restriction of blood flow for some reason or the other, that blockage interrupted flow such that now you have a lack of homeostasis or lack of steady state between the metabolites and oxygen at the tissue bed. So that is still going to be a trigger for vasodilation. Okay. And then whenever the blockage is released, we're then going to have increased flow because of decreased resistance from the vasodilation, and then we can clear the metabolites and deliver more oxygen. So the second reason that we might see reactive, or the second reason that we might see tissue hyperemia is a reactive hyperemia to a blockage. I'm going to pause here and see if we have any questions on those two things so far. So how increased metabolic demand, how that differs from a reactive hyperemia, which is where we had a blockage. Any questions on that so far? Okay. So here's just a comparison of those two things. Okay, we have active hyperemia, which is where the metabolic demand of the tissue increases. And so the oxygen consumption is more than is being delivered, and the CO2 production is more than can be cleared. Okay, so we have excess CO2 and a deficiency in oxygen. So that triggers the vasodilation increase, which decreases resistance as we relax that smooth muscle, and that brings more blood flow to the region, consequently bringing more oxygen with it, and then allowing more of that CO2 to be cleared, which puts our tissue back into a place of steady state, adequate amounts of oxygen, and decreasing the levels of CO2. And that can be a negative feedback mechanism to then go and restore the gas levels, which then goes and restores the state of the smooth muscle once that metabolic rate goes back to normal. So this is active hyperemia, and we can compare that to reactive hyperemia. So there's no increase in metabolic demand here. Instead, we have a blockage to blood flow. So the blood flow to the area decreases, and then that also results in less oxygen, more CO2. We have the same sequence of events, and then that can be shut off whenever the oxygen is increased to the level needed, and the CO2 is decreased to match the level that's being produced. Okay, so same exact mechanisms, same exact responses. The cause is just different, right? One is more metabolic demand, and one is previous interruption in blood flow.